So I want to now talk about actually some of the illnesses that people have. Let's go back to 2002. I think it was September, New England Journal of Medicine. You published an article on WTC cough. Could you just tell us what happened to WTC cough anyway?
Well, first, it's interesting, you know, we coined that term here purely by accident. We realized that it was cough, which we'll get to in a minute, but we would write on the chest x-ray, for the clinical reason, WTC cough. And the patients, when they were taking the form into the x-ray room, started saying, oh, I've got WTC cough, because they saw it on the chest x-ray. And that's true, that's what they had, but we originally didn't think that it was going to become the name of the syndrome. So the firefighters sort of named it themselves. So while 100% of our workforce had cough and sore throat initially, when you look 1 year, 2 years later, that symptom actually reduced the most. And we are now left with only about 10% of our workforce with a chronic cough and chronic sore throat. What was less common, but still very prevalent, was shortness of breath, air hunger, shortness of breath with exertion, wheezing. That was present in about 40% of our workforce initially, and persisted at 40% for many, many, many years. And now is running about 20% of our workforce, of our World Trade Center exposed workforce, whether they be active or retired. In terms of the upper airway problems, we had an immense amount of chronic sinus nasal congestion, and that has persisted at an even higher rate than the lower airway problems. While the lower airway problems are more of concern because they represent diseases that may have life-threatening consequences, the upper airway problems are of greater concern in terms of quality of life.
So the other striking finding from the early days was this loss of pulmonary function. And again, it was the article in which you and Tom Aldrich described it, beautifully portrayed how a large number of firefighters, and I think EMS personnel as well, the average loss of whatever index of pulmonary function you used, in this case I think it was forced expiratory volume in the first second, was large, and it continued over time. And I know you published this year 14 or 15 year follow-up, I guess 14-year follow-up. And you have similar findings. Can you explain that?
Yeah, this was the benefit of having pre-9/11 health data. Prior to 9/11, the lung function was dropping about 30 milliliters per year, which is exactly what you'd expect with normal aging.
Sure.
And demonstrates that self-contained breathing apparatus is working, right? In the first 6 to 12 months after 9/11, there was a drop of 375 milliliters in the firefighters. There was a drop on average of 268 milliliters in EMS workers. So we're talking about a drop in firefighters that was about 13 times what you'd expect in a typical year.
Right.
In EMS workers, it was nearly 10 times what you'd expect. The question has always been, what is going to happen? So we published again in the New England Journal of Medicine in 2010 and in Chest in 2016 where that lung function has gone. And in speaking about averages, there's been no recovery in lung function. And that is very unusual. Typically after a smoke inhalation event, you have a drop in lung function, not as severe as what happened here, but you have a drop in lung function. And then 2-3 months later, with and often even without treatment, lung function returns to its baseline. Here, you had a drop of 350 to 380 to 400 to even higher than that in certain people. And it's persisted on average. A flat line adjusted for aging. Now again, within that average, you have some people that have recovered and you've had some people that have declined even further. But on average, it's persisted.
So does that mean this very broad population-based loss of essentially reserve of pulmonary function Has that meant now, 15 years later, that some people have developed emphysema earlier than they otherwise would have, or some other chronic lung disease?
Yeah, and I think it's more complicated than that, but there is a group of people that are developing those type of severe chronic lung diseases that are reflected in abnormal pulmonary function at a higher prevalence than would be expected. Diseases like emphysema, pulmonary fibrosis, though luckily only a handful of patients have come down with pulmonary fibrosis, sarcoidosis, where we have nearly 100 patients that have come down with sarcoidosis after 9/11. So yes, that is part of this, but a larger number of patients, all right, are suffering from asthma, where their lung function is not the primary predictor of the quality of their life. Because as you know, while emphysema and pulmonary fibrosis, there your sense of breathlessness is in large part reflected by your loss of pulmonary function over time. Asthma is a hyperreactive disease. So you can have this, for the most of our asthmatics have had this drop in lung function, which has then persisted and has not gotten worse, but their symptoms are based on the irritability of their airways to irritants, dust, stress, extremes of temperature, exercise, and that's not reflected in their FEV1 or their forced vital capacity. Their symptoms, their quality of life is far worse than what their FEV1 would predict.
Does that mean there's some sort of interaction between the loss of FEV1 that occurred, immediately after September 11th and their asthma, such that their asthma, in a sense, is worse than it otherwise would have been, or is expressed, the symptoms are expressed a little differently than your average asthma patient, you think?
I think the symptoms are, for the most part, expressed the same way asthmatics are in terms of their provocability or irritability to these stressors.
By the way, that initial loss of 350, 400 cc's in FEV1, what do you think happened in the lung? What was the pathophysiology?
So the pathophysiology, we believe, is due to chronic inflammation. Right? For reasons that we don't understand, the dust and the chemicals, this mixture of toxins that was inhaled, for a variety of reasons that we can only speculate on. The high alkalinity, right, pH of 10 to 12 to 14, the larger particles that got down there unexpectedly because of the huge density, meaning that the upper airway couldn't filter it, the irregular shaped particles, all of that seems to have triggered an acute inflammatory reaction that persisted and translated into a chronic inflammatory reaction. Working with Dr. Michael Wyden at NYU, we've done over 10 studies now on anti-inflammatory markers, biomarkers of inflammation, and many of them are elevated.
So what evidence is there really for chronic inflammation in the lung parenchyma or lower airways that produces this fixed defect in pulmonary function?
Well, the amazing thing is that this evidence for chronic inflammation occurred within months after 9/11. We drew blood, and it's been analyzed by Dr. Michael Wyden and his laboratory at NYU. And there was demonstration of a host of increased cytokines and inflammatory biomarkers. We are now redrawing blood and showing persistence of some of these markers. We also are seeing early on and now that many of the respiratory problems, chronic sinusitis, the drop in FEV1, and we think asthma and hyperreactivity, though we're not certain yet, are predicted by eosinophil levels. Even eosinophil levels that are elevated but still within normal limits. So again, this concept of having pre-9/11 data, of knowing who your people are, is adding extra value. What we've shown is that as a population, as a cohort, the diseases, the respiratory diseases, are continuing to occur at an extent greater than what we would normally have. Dr. Charlie Hall has done some very sophisticated time change point analyses and looking at the date of our first diagnosis for respiratory problems and for sinus problems, looking at the date of the first symptoms, and has demonstrated that for respiratory and upper respiratory diseases, these are continuing to occur 6, 7, 8 years out at a higher rate than we had before, and most importantly, still with an exposure response gradient, so that the people who were there during the morning of 9/11 are having 6 years out a higher diagnosed rate of respiratory and sinus problems than those people who were there for the first time many days later. So can we have absolute proof that this individual is having World Trade Center related asthma versus regular asthma 10 years later, 15 years later? We can't, because there's no specific pathognomonic marker for this. But can we say that as a group we're having higher prevalence, higher incidence rates with an exposure response gradient that has persisted? That we can say with great certainty.